I'd like to introduce our first presenter for the afternoon. It's Dr. Beth Rosellini. All right. Dr. Beth is a fourth-generation dentist who's built a very robust family practice down in the Dallas, Texas area. All right. She initially trained as a scientific researcher at the University of Texas in Austin. As an undergraduate, went on to Texas A&M, Baylor's College of Dentistry, correct? Yes. Mm-hmm. Where she basically developed a passion for patient care and clinical research. She describes her philosophy of care as basically focused on healthcare instead of traditional Western medicine sick care. All right. She often collaborates with other like-minded healthcare providers in her community to provide patient outcomes via thoughtful comorbidity management and ideally prevention against or prevention versus proactive care via proactive care. Excuse me. She spent the past 5 years devoting more of her time to sleep-related issues, specifically in children, relating to optimal growth and development and airway management. Okay, so at this time, Dr. Beth Rosellini.
Thank you. Gosh, you made me sound so fancy. I really appreciate it. Okay, hold this. Sleep disorder breathing. I'm really excited to give the talk. Before we get into it, a few disclaimers. Number one, I work with the Healthy Start. We're going to talk about their therapeutic solutions. They have compensated me for my time here, but in no other way. So when I start talking to you about what appliances to use, those kinds of things, there's no other incentive. It's just because I really believe in it. I really believe in the research. And I'm actually a patient. I was treated as a child with this same therapy. So I'm going to tell my story later on, but really believe in the system. Second disclaimer, these are not the slides that are online. And I know dentist types do not like when they don't get the handouts that match. That happened for two reasons. One, I think if I had given my planned presentation, Dr. Fisher may have decided not to invite me to come and speak. And then two, after just this my first meeting with this group of people, after seeing how people talk and present, I really wanted to give something that I think you guys would really like and get you really excited. So I've had such a lovely time hearing the other talks, and I just really wanted to raise my game. So we'll see how that goes. But if you'd like it, feel free to email me, text me, you can Instagram DM me, whatever you want. I'd be happy to send you the full presentation. Any information you want is yours. Okay, so a couple of people, and I think I keep going in and out of the volume, so let me know if you can hear me. Oh, okay. Another big disclaimer, I've had a couple of people ask me what I'm planning on talking today. Kind of, did I invent this? How did I discover it? Am I an original researcher? No, I'm not. All of this research has been around, started about 50 years ago. I know that's really fun to watch. But Dr. Bergerson has been doing this research for about 50 years. He is 82 years old. He does not get around to lecture all that much. He's actually lecturing at this meeting in September. I think it's his only lecture he's giving this year. So I highly recommend, if you're in Boston, go and see him. He has over 500 patents. He's been an instructor at a bunch of different universities, and he is a genius. And it's really fun to get to come and present a lot of his research. I've had the benefit of just being able to connect with patients and use this in my practice, and that he's allowed me to be a part of his legacy and kind of continuing to spread the word, help educate people, and inspire them to kind of help their communities in this way. And if you don't know who Dr. Bergerson is, I like to joke that he's just kind of a big deal. So you should definitely come and watch him speak. He's awesome. So today we're going to talk about outward signs and symptoms. What is sleep disorder breathing or sleep-related breathing disorders? We're going to talk about currently how those symptoms are being treated and handled in medical practices as well as dental practices. And then I want to talk about some of the proven therapeutic options that some of you may or may not have been exposed to in the past. 2 years ago, there was a study of about 500 and some odd patients, just taking a snapshot of how do they present themselves in our practice on a day-to-day basis on a variety of different symptoms. It was published in the Journal of the American Orthodontic Society. From that study, you can see this long list of different symptoms. snapshot of the general population of our kids is that they are not that well. They have signs of chronic inflammation showing up in a lot of different ways. Everything from chronic allergies, asthma, hyperactivity, symptoms of ADHD, speech problems, difficulty breathing at night, open mouth breathing, a lot of different things that we just kind of get used to, or we excuse away, or we say it's normal, or we say it's environmental. In fact, there's a root cause to a lot of these symptoms. The study, kind of higher level, what did we conclude from it? 60% of these children had 4 or more of these symptoms. One of the most shocking things that I was really surprised by is that 1 in 5 children have prolonged bedwetting. So beyond the age of normal potty training bedwetting. And we'll get into the reasons behind that. Doesn't get talked about a whole lot because there can be some shame associated with it, some embarrassment either from the children, from the parents, because they just think, what am I doing wrong? There's not great resources online when mom is up at 2 in the morning washing the sheets and trying to figure out, how do I help my child thrive, behavioral modification. But as you can imagine, if you're an 8-year-old child and you're still wetting the bed and you can't go to sleepovers and you can't figure it out and you're changing your diet and mom is stressed out because she's still changing the sheets, or you're having to wear a diaper, how stressful that can be, and the long-term implications of that, psychologically, socially, emotionally. So just really big conclusions that we were able to see when we said, what is the reality of what our kids are dealing with day to day? On top of all of that, almost 93% of these symptoms never self-correct. So between 2 to 19 years old, it's not as if they just grow out of these symptoms, which may be language that sounds familiar that you've heard before, how people talk about it. And then almost a third of these symptoms get worse as they get older. What do these symptoms actually look like? So statistics are interesting and fun, but when you actually see it on the faces of children, it's pretty sad. They don't look happy, vibrant, like they're thriving. Most kids want to feel great. They want to go play. They want to go to sleepovers. They want to have fun. But because we're not addressing the root cause of what's making them not sleep and have all of these other chronic inflammatory issues, they don't feel wonderful. If any of you guys are familiar with that old ad from Nancy Reagan about drugs in the 80s, where she says, this is your brain on drugs, and she has the egg and the fried egg. Okay, thank you. I like to use that comparison for this. This is your brain when you're sleeping well. This is your brain when you're sleep deprived. Your brain is just not working properly when you're not sleeping. And the trickle-down effect of that is enormous and affects every biological, biochemical process in your entire body. Here is my attempt to be as cool as all of the other presenters this morning when they showed all of their great research. I just like to stand on the shoulders of other awesome researchers and present their stuff. It's been around for about 30 to 40 years, some longer than that. But the correlation between what happens with prolonged sleep deprivation starting as early as 2 years old, how that shows up over and over again as they get older. So behavioral issues, higher predisposition for obesity, diabetes. We see the association of the plaque that forms in the brain associated with Alzheimer's disease, dementia. Going on, 77% of children with Down syndrome really struggling with sleep issues. Bipolar patients having much more sleep symptoms than we would typically expect, or I typically thought, but when it actually gets treated, how it can improve some of those symptoms or the presentation of that disease, that disorder. So just study after study after study after study, linking all of these major clinical presentations of symptoms to sleep disorder breathing. So I just say, help me help you. I'm not the researcher behind all of this. Take my word for it. It exists. I'll send you the list of all of them. Let's talk more about the clinical presentation. Sleep disorder breathing, how does it show up in our dental chair? It has been tied to mouth breathing, having narrow palate, improper tongue placement, and jaw relationships. How many people in this room as a dental provider are familiar with those 4 things? Awesome. Okay, you can put your hands down. How many people think your local pediatrician is evaluating the patients in their practice for these things? Thank you. I got a big goose egg from over here. That's actually the correct answer. They're not. And that's the primary referral when patients are having issues with sleep. If it's even being brought up, it's going to the pediatrician. And they're not looking at this head and neck anatomy. What does their airway look like? What else is going on? So not only are they looking for it to see if it's a problem, they certainly don't know to refer it to a dentist who is educated in this and knows how to treat it and get this kiddo back on track. I have a couple of examples just to show you how severe sleep disorder breathing, open mouth breathing can be as related to collapsing the airway. So a typical 7-year-old should have a 7-millimeter airway anterior posterior. If they have their mouth open just a ½ inch, that equates to 6 millimeters in compromise in their airway. So a 7-year-old can have just 14% of their airway available to them if they're open ½ an inch. That's when they're asleep, that's when they're awake, all the time. So if you see a kid walking around with their mouth open, you already know that they're not thriving, they're not getting the amount of oxygen and airflow that they're supposed to when they're walking around. We did this side by side for a CBCT to help educate some parents, because sometimes they just don't get it when you're really trying to have this paradigm shift, or if they say, oh, you know, dad snores and he's fine, or he'll probably grow out of it, or older brother snores and he plays soccer and he's on varsity. Yeah, okay, so he's doing well, but imagine how well he could do if we actually got him breathing the way he's supposed to. We got him sleeping the way he's supposed to. And as soon as we show them a side-by-side of this is how your kid is actually breathing when he's sleeping at night with his mouth open, they just are shocked and they understand immediately. Another good example I like to give is breathing through a straw. So going back to that 7-year-old with a 7-millimeter airway, if you think it's compromised 14%, that's the equivalent of having to breathe in and out through a coffee straw. I would encourage all of you, when you go outside for a coffee break this afternoon, get a coffee straw and try to breathe in and out through your mouth with it. It is very, very uncomfortable. And these kids are going to school, they're going to practice, they're having to deal with twerpy younger siblings, they're having to do chores, and they're just not getting the resources they need for their brain to be firing how they want it to be, for their bodies to be recovering, and to feel really great. But if we get their jaw in the right position, their airway nice and big, just like breathing through a fire hose, they feel so much better, so much more vibrant. But it really doesn't take much in order for it to be compromised. I liken sleep disorder breathing to Napoleon Dynamite syndrome. Those root causes are mouth breathing, narrow palate, improper tongue placement, and the jaw relationships. So when you see kids walking around like this, preteens, you know that they're not thriving. Ideally, after this talk, at the very least, you can start having these conversations as soon as these kids are in your community or at least in your practice. Going back to that long list from that study of the 500 kids, some of these big symptoms, chronic allergies, aggressive behavior, nightmares, delayed stunted growth, bedwetting. Do we think these kids feel good? Thank you. No, they're not feeling good at all. Does anyone want to say how we're typically treating these types of symptoms? Oh, have you guys heard this talk before? Yeah, no, I'm teasing. Yeah, no, you're exactly right. Oh, put the Sarah McLachlan sad music, not to make fun of such a serious topic, but it is tragic what is happening with them. Yeah, we're spoon feeding them medications. We're barely treating the symptoms. Yes, there are some things that we're doing, a really great push on nutritional health with children, getting off gluten, getting off dairy, awesome. But that's just some of the symptoms. We're giving them medication, they're going to other specialists who maybe they're spending an hour or two a week with to try speech therapy, try occupational therapy, behavioral therapy, a psychologist. That's, again, just masking, trying to mask some of the symptoms, but none of those people, none of those current solutions are addressing those root causes, that Napoleon Dynamite syndrome. And then to make matters worse, some of these solutions that are being used have their own bag of issues as a downside. So yeah, okay, we're going to keep you awake in math class, but we're going to make you grouchy and irritable and have all of these other issues that now mom and dad are having to deal with as they're trying to help their kid reach their full potential. And as a great philosopher of our generation says, these Band-Aids will not fix these bullet holes. This is Taylor Swift. If you guys are not familiar, she's not a great philosopher. This is to keep things light after lunch when maybe you're feeling a little sleepy. But that's really what this is. It's a whole long list of Band-Aids. No one's talking about the palate. No one's talking about the airway, the jaw relationships. 'Cause baby, now we got bad blood. You know it. Let's say a best case scenario, some of the kids in our community are actually paired with a pediatrician or a physician who knows something about sleep. And they say, I think maybe, or maybe they've exhausted all these other measures and the kid is still struggling. They said, let's do a sleep study. I don't know what's going to happen. Oh, sleep is an issue. Diagnosed. First solution, first therapy is a CPAP. How many of you have children? Can I see a show of hands? How many of you, so leave your hands up. Keep your hands up if you think your child would like wearing a CPAP every single night. No one? If you don't mind me asking, does your child wear a CPAP? Does he like it? He hates it. Okay, but he wears it because it keeps him alive, basically. Okay, thank you. I may call on you a little bit more if you don't mind. Okay. This story really tugs on my heartstrings. This is a patient in my sister and I's practice. Was referred to us by the local hospital. Issue being, got the diagnosis, got the CPAP, but was in a household where mom sometimes forgot to pay the power bill or didn't pay the power bill. So there were times when the kiddo said, I want to feel good, I want to be able to sleep, I know I need my machine, but sometimes the machine won't turn on because the power isn't turned on. And that's just tragic. So ideally at this point, you are aware that as dentists, you are the #1 people who should be on the forefront of having these conversations, diagnosing these kiddos, educating family members, and treating these root causes so that none of these symptoms ever even show up. When you are able to get rid of some of those symptoms and make kids feel that vibrant, happy, playful, well-rested, awesome kiddo that they always knew that they could be, that's the most rewarding dentistry I've ever done. I didn't even know it was possible when I was in dental school, and it is the best practice builder because every single one of these patient families, they become your #1 raving fan. They say, you changed not only my kid's life, you changed my whole family's life. Everyone's sleeping better, everyone gets along better, and now you're getting referrals from their classmates, from their other family members, and you just can't turn it away. You become the #1 person in the community to help these children. And then if that doesn't inspire you enough, I'll say that in 2017, yeah, the ADA, which I know that's a polarizing opinion of the ADA, but they're coming in and trying to bully dentists to really take this more seriously. They came out with a formal statement saying that in fact, dentists should be the front screener of sleep disorder breathing in children. We should all be screening children for sleep. How are they sleeping at night? How they define this, any disorders characterized by disruptions in their normal breathing patterns. Serious medical conditions caused by this anatomical airway, snoring, upper airway resistance, obstructive sleep apnea, all things that even the ADA says that we should be screening for now. That's brand new, or relatively brand new. I'm going to say that a lot of our parents are becoming more educated. They're getting frustrated. They've had the medication, they've done the therapy, they've tried the diet change, they have them in the alternative schools. They're doing everything they can, and they know that that's still not doing it. There's still something wrong. The kid is still not thriving or still not feeling great. This is a mom in the back seat with her child. It kind of explains it as she talks about it here in the video. Oh, there's sound to this. And press play.
He's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Now watch. He's holding it. He's holding it. He's holding it. He's holding it. He's still holding his breath, and then he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. He's trying. There he goes. So this has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now watch what happens when I take his jaw and I just bring it forward. If I can, let's see if I can. And I open his airway. Just bring his airway forward. Now listen to the quiet breathing. There we go. Now he's breathing through his nose. And I brought his airway. I'm opening his airway, just pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little bit open, but he's breathing through his nose. Just by hear how quietly he's breathing, you don't hear him anymore. And all I did is gently bring his jaw forward.
So I think this is super powerful. Parents are smart. I normally say moms are smart, but moms and dads are really smart. People who are just in touch with their kids, they see them every day, they see how they feel. There's just an instinct of just what's happening, help my kid survive. My kid is choking. Even if you've never done sleep dentistry before, you've never done sleep medicine, just intuitively as human beings, if you can imagine as an adult, but even as a child, if you are choking, what happens to your heart rate, what happens to the cortisol that gets released in your body, when your body is now saying, oh, I don't care about repairing cells, I don't care about turning over cells that are dead. I am in high alert emergency mode because I'm gonna die if I don't wake myself up, if I don't self-perform CPR, jolt my jaw forward, or wake my body up to get myself awake. A lot of people think that if you're not snoring, you don't have sleep apnea. In kids, it presents pretty differently. They don't have to have any snoring at all, just audible breathing. Of course, if you're not breathing at all, that's sleep apnea. And just as simple as bringing that mandible downward and forward, restoring that nasal breathing, you can see how much better he's sleeping just immediately. And if he's breathing with his mouth open, interrupted breathing, even once an hour, but multiple times an hour. I mean, this kiddo was, I think she said a couple times every 3 minutes. He doesn't want to go to sleep. His body is saying, hey, wake up in the middle of the night, go to mom and dad's room. Maybe his body is saying, hey, wet the bed, high alert, all the signals turn on because something is wrong and we need you to be awake because you're choking in the middle of the night. So what's the solution? The first is just knowing that this exists and being able to diagnose the problem. Then it's educating. So if any of you have not been aware of this before, imagine parents who've been out there that have never heard this before. The education becomes even harder when you say, well, dad's on a CPAP, or mom has TMD and she's fine, she grinds all of her teeth and she doesn't sleep well, but she has insomnia. So it's a major paradigm shift, but I'm really encouraged by coming here and connecting with all the doctors here because you guys are used to having those hard conversations. You're used to introducing topics that are either less popular or have not penetrated your community. So you're comfortable going out there and leading your community, leading your patients to the right solution that is that whole body health that really helps the whole family feel and do a whole lot better. So after the education, eliminating poor oral habits, so thumb sucking, the tongue thrust, getting the tongue in the right position, anything that's going to keep the jaw relationship in the wrong position, digit sucking, lip sucking, if they have nasal inflammation and they're just used to mouth breathing, how do we eliminate those poor oral habits? And then early interventional therapy. We're going to get to that, but that's the direction we're going in. There are so many cool gadgets that you can invest in that I'm not here to hawk. I love them. I like to use home sleep tests on kids because I like science, I like data. I also love our CBCT because it just really visualizes what's going on with the kiddo. But I will tell you right now, all you need to start treating this in your practice, start identifying it, is a questionnaire. Every single, if you take one thing away from this meeting or from my talk, besides the fact that my meme game is pretty solid, it's that all you have to do is start asking people how they're feeling. Every single patient should be filling this out. They're there for hygiene, they're filling out this questionnaire. They're here for a crown, they're filling it out. It becomes part of your paperwork because they have no idea that they will start the conversation, even if you're not comfortable. As soon as they say, why is my dentist asking if my 6-year-old still wets the bed? Like, yeah, he does, but what is she gonna do to be able to help me? It starts that conversation. You can start educating them. And so many of these parents are so desperate to find a solution for their child that they're like, thank goodness, where have you been? I've been looking for you for years. I've been up at night on Google searching to how to help my child, and all the physicians tell me is put them on more medication. And I'm so frustrated. And now my child has been, the trajectory of that child's life, he's been held back in school. He's not been able to go out for the sports team. He's not going for the sleepover with all of his friends, and he's on this restricted diet and all of these things, and it's just getting them to sleep better. So asking these questions, every single patient, and even if you don't have a lot of children in your practice, again, a good way to grow it. Everyone knows a kid, but even as soon as an adult fills this out for themselves, because you'd be surprised how many adults also have these symptoms, and they say, yeah, we can help you, we can talk about adults as well, but if you have your kids experiencing any of that, bring them in here. Let's do an evaluation, because there's a way that we can help guide their growth and development, catch it before it becomes a major problem, so that they can grow up and have optimal systemic wellness. So getting into the therapeutic solution. This is the Healthy Start solution, and I'll be very candid with you. There are competitors, there are other devices that you can use. I'd encourage you to come and ask me, go ask Jason in our booth, what's the difference? Why do we like one versus the other? I am so passionate about this. I will say use whatever you decide works for you. I like it, I work with it, I've been treated with it, so I believe in it. But whatever you decide as the device for the intraoral appliance therapy, for this early intervention therapy for children, start using it as soon as you can. The number one appliance that all of these children are going to be in is what we call a habit corrector. This is Dr. Bergerson's, if he were Steve Jobs, I think this is his iPhone. It is so brilliant. It is a small little appliance that the kiddo wears at night that does so many things at one time. Positions the tongue exactly where it needs to be, helps guide the teeth where they need to come in. It has the mandible downward and forward and holds it there all night long, promotes that growth, downward and forward growth, so the TMJ is nice and healthy as well. Everything you could possibly want. My sister and I practice together in Dallas, and we've kind of, I don't want to say had the happy accident of becoming a major referral for most of the doctors in our area who have children that they just can't help or they've had issues. My sister specifically has partnered with some of the ENT faculty at UT Southwestern to treat their children with Down syndrome. If you guys are not aware, the current treatment or accepted standard of care for children with Down syndrome, which previous research on my other slide said 77% of kids with Down syndrome have issues with sleep. The current accepted standard of care is adenoid tonsil removal, ear tubes. Typically when they're sedated, they're going to get an RP in their roof of their mouth, which by the way, they don't like that texture. They don't like being put to sleep and waking up with something glued into the roof of their mouth. It's very bothersome to them, very disruptive, doesn't help with the speech. They also do tongue reduction, which is just where they shave off part of the back of the tongue to try to make the airway bigger. And then more often than not, they're being put on a CPAP for lifetime, which if we have adults, I think the adult failure rate for a CPAP is 40%, something astronomical. Or we have a healthy kid who knows it makes him feel better, he or she makes him feel better, who still hates it. How do you think a Down syndrome kid is going to do with a CPAP? We think they're going to be successful? No. So I'm going to play these two videos. This is, again, a mom home video. So that's snoring, not great breathing. He has some interrupted sleeping as well. Mom snuck in, because at first when he was first getting used to it, this is in, I think, the first week of his therapy, he was still getting used to it. It would fall out at night, he would fall asleep, and then mom would go in and sneak it in, or he would fall asleep on her chest just as he was getting used to it and sneak it into his mouth. Sleeping soundly, no labored breathing. Again, in kiddos, obstructive sleep apnea is not snoring, it's not sawing logs like you think of in adults. It's just any audible breathing. So we go from this audible breathing, borderline snoring, to sleeping soundly. And what's really, I like to use this example just because it's a really great story, but sometimes Down syndrome, children with Down syndrome can be an intimidating patient population, at least how it was taught in my dental school. It was, oh, leave that to the specialist. It requires a lot more sedation. Absolutely not. As soon as we get mom, we partner with mom, and these are really inspired parents who are really engaged and want to help their kiddos, or inspired parents, the kiddo starts feeling so good, they start reaching for it. They know they feel better when they have their appliance in. They know that they want to be wearing it to go to sleep, to really engage and get the kind of sleep that they want. And that CPAP restricts that maxillary growth as well. So it's, again, it's not as bad as the stimulants and how you have the downside of the effects of those pills, but it's presenting a whole different set of issues as a downside with the CPAP. Talking about speech therapy. So we don't want to replace speech therapists. We like our speech therapists. We partner with them quite a bit. They actually like that we make their therapy more successful, that they get expedited results with a lot of their patients. It's just a math problem. If you can think your child going to speech therapy, maybe they're there 1 hour a week, 2 hours a week, so they're getting 120, 240 swallows per week of reinforced therapy, and that's if they're really on it. Maybe they're doing some at home, as opposed to giving them appliance that reinforces where their tongue needs to go every single time. How many more swallows you're getting with just an intraoral appliance that they're wearing at night passively. And I also think this is important. Any adult that you meet who says, hey, I had ortho, but I have permanent retainers on the upper and lower, and I have a tongue thrust, and actually my tongue is so strong, I broke off my permanent retainer on the upper and lower, and I've had major relapse of my ortho. Yeah, your tongue was never trained to be put in the right position, so of course that's going to be a problem. Do you have a sleep issue too? I bet you do. Not to laugh at that, that's very serious, but the beauty is when we start early, we can then guide the teeth in the mixed dentition so that the teeth, the adult dentition, becomes the retainer. It holds the jaws in place to keep the airway nice and open so that that child thrives all the way through adulthood. How do we know this works? Well, Dr. Bergerson has been studying this for about 50 years, as well as a lot of other doctors. We know within great precision, predicting based on the size of the pediatric teeth, the deciduous teeth, how big the adult teeth are going to be. So we can size the appliances to know exactly how to guide those teeth through mixed dentition, exactly how much arch length we need, exactly how much spacing we need. So we can guide those teeth all the way in, they're stable, and they have a straight, nice smile before most of their other kids are in their classroom have even gone to the orthodontist for their first referral. Another intuitive thing that I like to compare it to, I don't know what the orthodontists, and we have orthodontists that use Healthy Starts, so I'm not trying to dog on them, but at least some of the ones that I train next to in dental school and I see them in practice, they say, oh yeah, you have some crowding, wait until you're done with growth and development, wait until all the adult teeth come in, and then we'll put braces on and we'll straighten them out. Not addressing sleep, not addressing airway issues. If you imagine if we can capture these teeth as they're coming in, no PDL fibers are attached to the root is only partially formed. Those kids are nice and slippery, those teeth are nice and slippery, we can put them exactly where they want to be. But if we wait until they're 12, 13, 14, they have no growth and development left, no puberty left, we're having to sever, stretch, break these PDL fibers in a best case scenario, so maybe they work. Otherwise, they're going to have relapse. Kiddos, that early interventional therapy before they've gone through puberty, they are like wet clay. We can mold them, they are easy, we can guide them, their jaws want to go where they want to go, and their behavior is, they're pleasers. They haven't gone through the preteen, I don't want to listen to mom, no dentist, I don't want to do that. They want to be guided to feel great and get on the right path, as opposed to that traditional ortho of wait until they've gone through puberty and we'll smash and break and get them in the right spot, using metal and extra forces to get those teeth where aesthetically we want to go, but maybe helps the airway, maybe not. Here are a couple of cases. I'm going to go through these fairly quickly because I'm coming up on the end of my time. This kiddo presented with a ton of symptoms: bedwetting, restless sleep, attention deficit disorder. What else is he dealing with? Allergic symptoms, excessive sweating. This is what he looked like when he came in originally. Excessively deep bites, so jaw relations, big issue. Archway isn't as big as it needs to be. When he came back for his first, well, he came back other times. You can see how we corrected the deep bite. So this would signal that we brought the mandible downward and forward. If you go back, this follow-up, look at all these symptoms going from a 4 of being moderate to severe to 0. The kid doesn't even have the symptom anymore. So fixing the sleep, but then also using the teeth to stabilize where he needs to be. And this is him as an adult, never had bands and brackets, never had traditional ortho, wearing an appliance at night. Another case, seeing resolution of a lot of these symptoms. I think this is another restless sleep, attention deficit, waking up in the middle of the night, bedwetting, coming in initial, excessive deep bites. So mandible wasn't in the right position. Mandible was choking the child probably in the middle of the night, bringing that mandible downward and forward, expanding the arches, and then having those adult teeth stabilize the case. It's another great case, lots of crowding, narrow arches, narrow palate, finishing the case. The nice, healthy, broad smile. Aesthetically getting the results that parents think that they want eventually, but doing it so the kid is also really super healthy. Another case, the appliance in the mouth. The therapy that you actually end up using, maybe you use a couple of different appliances. You have the habit corrector to start to get rid of all the symptoms. We want to make sure all of the myofunctional balances are in place, the tongue's in the right position, the cheeks are in the right position, they're swallowing correctly, they're breathing through the nose. Once all of those symptoms are gone, we've resolved all those root issues, then we just use an orthodontic appliance to guide the teeth the rest of the way. And the beauty of it is the majority of the actual operator time is done by my dental assistant. So she loves that as well because she's doing things that she never thought she would do in a traditional dental practice. Here's another great case. So this has to do, this child was, I think, 2.5, actively asking for the appliance because it makes him feel better.
Awesome, awesome.
So this is my story, just to wrap. I was a severe thumb sucker, and it was so bad. My dad didn't have his clinical records of me when I was younger, but I had an arch that was almost V-shaped. My dad jokes now that I'm an adult, but it was almost like a field goal. The space between 8 and 9 got so severe. My thumb sucking was so bad, he actually, this was before the habit corrector was developed, there was just the orthodontic appliances, but he used rulers and would ace bandage my arms to try to break the habit because he knew it wasn't good for me. He searched high and low. General dentist, had not done a lot of pediatrics. He took me to the orthodontist, and they said I was going to be a 4 on the floor extraction case because I was so crowded. And he said, absolutely cannot do that to my daughter. There has to be another solution. So I'm grateful he found Dr. Bergerson and he found this system. And I mean, I get to brag about my smile because I wasn't the dental provider that did it, but I lived and breathed it. And I was a really hard case. I had horrible habits, and my tongue was messed up. And he allowed me to be in this appliance at night. Granted, my mom was engaged; she was on board. So many of my chronic allergy symptoms, I had really severe eczema, all of these things that we didn't even know were related. He was just trying to solve my airway issues, were resolved. So I get to be a poster child for it, literally, but I really believe in it. So again, if you guys want these slides, please come and find me. I'd be happy to share them. Email me, text me, whatever you like. If you have a kiddo, I know that Jason, he's here in the back. He has some extraordinary special where if you sign up, all of the educational stuff can be done from the comfort of your own home if you're really interested in this, in a digital webinar course over a number of different weeks. And I think today he's offering, you get 2 free cases. So if you have children in your practice that you want to give this a go, or your own children, you want to try to treat some of their symptoms, this is a great time to sign up. I think maybe I have time for some questions, or if not, I'll be on the panel this afternoon.